Afternoon, distinguished speakers, colleagues, and participants joining us from across India and the Southeast Asian region. On behalf of the Patient Safety and Quality Cell, AIIMS New Delhi, and the World Health Organization Southeast Asian Regional Office, I warmly welcome you to the second webinar of the regional webinar series on patient safety. The theme of today's webinar is Patient Safety Program, Incident Reporting and Learning. Patient safety remains at the heart of quality healthcare. Today's webinar will focus on building effective patient safety programs, strengthening incident reporting systems, learning from errors, and fostering a culture of continuous improvement. We are delighted to have an eminent panel of experts with us today and look forward to an engaging and insightful session. Without further delay, I invite Dr. Aparna Singh Shah, the Regional Advisor for the World Health Organization Southeast Asian Regional Office, to deliver the opening remarks and set the context for today's webinar.
Good afternoon, respected Dr. Srinivas, distinguished colleagues, participants, friends. It's a pleasure to join you today for this webinar session on WHO patient safety program focusing on incident reporting and learning. All of you are patient safety is a fundamental of quality of care. I'm trying to show you my slides. Just give me a moment. So coming back to the topic, I hope my screen is visible. Can you see my screen?
Yes, it is.
Okay, thank you. So patient safety is a fundamental pillar of quality healthcare, and incident learning and reporting are critical tools for understanding harm, strengthening system, and preventing recurrence. In today's session, I will briefly introduce WHO Patient Safety Program. So what you are seeing on screen now, the images you see on the screen remind us that patient harm in healthcare is not rare and is often reflects deeper system gaps. Poor quality causes an estimate 5.7 to 8.4 million deaths annually in lower middle income countries. Nearly 60% of deaths from conditions requiring healthcare in lower middle income countries are due to poor quality care rather than lack of access. 4 in 10 patients with chronic conditions do not trust their healthcare system, reflecting gaps in quality and patient experience. Poor quality care results in 1.4 to 1.6 trillion in lost productivity each year in lower middle income countries. In high income countries, 1 in 10 patients is harmed during hospital care, and in our countries, 7 in 100 hospitalized patients acquire a healthcare associated infections. So this number is even higher because we do not have very accurate data from all the member states. The data mostly we project as high income countries data. So WHO Patient Safety Program, global and regional context, World Health Assembly and Regional Committee resolutions. WHA 55.18 2002. First place quality of care and patient safety on the global health agenda. WHA 72.6 2019 and Global Patient Safety Action Plan 2021 until 2030 strengthened WHO's mandate to eliminate avoidable harm in healthcare. In Southeast Asia region, in 2006, there was a resolution in addition to Regional Patient Safety Strategy 2016-2025. This strategies has guided our member states in initiating action on patient safety. WHO's vision is to eliminate avoidable harm in healthcare and achieve highest level of safety for all patients. So the agenda has also been strengthened through global ministerial summits on patient safety hosted successively by United Kingdom in 2016, Germany 2017, Japan 2018, Saudi Arabia 2019, Switzerland 2023, Chile 2024, Philippines 2025. This year, we assume that this will happen in Oman. So on the screen, you can see on one side regional strategy objectives, on the other side global patient safety action plan. So the first objective of regional strategy and sixth objective of a global action plan discusses incident reporting learning. Why incident reporting learning matter? Incident reporting and learning system help identify patient safety incidents, near misses, system failures, enabling action to prevent recurrence. A strong incident learning system promotes a no blame culture, supports analysis and feedback, and turns incidents into opportunities for safer care. So this is very important figure. We collect data using global data portal for patient safety. And when we analyze the data for Southeast Asia region, incident reporting learning, as you can see on one side, is at some 43. And then global also the score is not very high, it is 49. So this part is not very well covered globally, especially in lower middle income countries. To establish patient safety, it is important to strengthen national and institutional patient safety programs, institutionalize incident reporting learning and surveillance system. You can see on the screen few things are in gray and I have highlighted in blue incident reporting learning because the rest of the topics will be discussed in our upcoming webinars in coming months. So incident reporting learning is essential to establish patient safety in healthcare facilities. Capture patient safety incidents, near misses, unsafe conditions, identify underlying system failures, contributory factors, processes, and improve outcome. Promote analysis, feedback, and learning to prevent recurrence, strengthen a no blame culture, and continuous safety improvement. Every reported incident is an opportunity to learn, improve, and prevent harm. A strong patient safety program transforms reporting into action and learning into safer care. Thank you.
Okay. So, good afternoon. Thank you, Dr. Aparna, for such a lucid session and for such insightful opening remarks that we could have. The next speaker that we have is Dr. Arun Mawaji. It is now my privilege to invite him. He is the Director, Growth and Strategy, MedBlaze. Dr. Arun is an internationally recognized expert in healthcare quality, patient safety, and hospital operations. He is a certified NABH assessor. He is also a CII Excellence Framework assessor and has led digital quality transformation initiatives across more than 15 countries. He will be speaking on patient safety program, development and role of a patient safety officer. Dr. Arun, over to you.
So good afternoon, audience, and at the outset, let me thank the Department of Hospital Administration, AIIMS New Delhi, and my co-speakers today for giving me an opportunity, and of course the WHO Southeast Asia Regional Office. Dr. Kaneka, I would like to ask, will you be presenting the slides or can I present the slides from my side?
I have your slides, so I can present
okay,
it.
Because I see that and the logos and all is present, so that's the reason I asked.
Yeah, sure.
Nevertheless, once again, thanks, and I will take forward from where Dr. Aparna Singh mentioned, especially a note on the current statistics of patient safety and some of the programs mandated by WHO and other things. So, my topic today is patient safety program, the development and evolution of patient safety officer. So what I've done is that I've tried to understand, what we have done in the last 25 years since the report to Errors Human was published, and try to understand how the patient safety program evolved and what it is currently and how it is going to be in the future, and what we can do necessarily to prevent harms from happening. Could you go to the next slide? In the way I can change the slides, no problem, that's fine. See, if you look at this particular important report to erase human, we still take inspiration from this report, and till today we look at the statistics published in this report to address the issues of patient safety. What the Institute of Medicine did 25 years back still remains the same. If you look at from what statistics Dr. Aparna presented, is no different from the numbers that were published in that particular report. So 98,000 preventable deaths were happening in American hospitals, and at that time when the report was published, everyone were flummoxed. Today also the issue remains the same. So we still have 1 in 10 patient getting harmed, 1 in 4 patients in ICU getting a hospital acquired infection. Till even today, we lose millions in dollars in cost of poor quality. Despite efforts from the WHO, efforts from accreditation bodies like NABH, premier organizations like AIIMS bringing about evidence-based best practices for everyone to follow. We have AI, we talk about EMR, we talk about committees and everything. So every year we learn, but what is it in practice, and what is it happening? We are unaware. Even today, we don't have a national reporting structure that corrects data regarding patient harm in a very systematic and a very standardized manner. So if you ask me what is the current real-time statistics of how many patients are harmed anywhere in Delhi or in Bangalore or in Mumbai, I'm not aware. So this is something as leaders who are there need to think about, and prepare ourselves, our hospitals, and our healthcare system to address this gap. Otherwise, we will be looking at the same statistics year on year. So that also brings to the question is how do we design our patient safety programs, and the most important person, the patient safety officer, who's going to implement all these policies, ensure these programs are effectively managed. What is this role going to be today and tomorrow is what we will try to understand. What I've done is, if you can change to the next slide, the last 25 years, we can look at by dissecting it to 6 different eras, because each era brought about a new perspective into the thinking of patient safety, and the role of patient safety officer was very different from what he is today. Patient safety officer with 25 years of experience may not necessarily be effective today, because the practices, the skill sets required are totally different. But history always teaches a lot. So that's one of the reasons why I wanted to go back before I go ahead. So between the years 1999 to 2005 was the first era of patient safety, where people were looking at incident reporting, error detection. Then the blame game culture was there. And then between 2005 to 2012, the second era of patient safety, where they looked at what we can do, how we can prevent harm, what are the standardized way of care that can be practiced. And of course, these were all evidence-based research that were published, and and how the patient safety programs were inculcated. And 2010 to 2018, where they looked at safety culture, not from a human error to a system thinking evolved. And then in the 2021 to now is where we look at creating safer systems. And the era next will be the predictive safety with the use of digital tools, AI, and other things, so where we are going to prevent harms from happening by way of digitization and use of artificial intelligence. Next slide, please. So going back between 1999 and 2005, errors were more common than were believed. And it was mostly because of underreporting. The adverse events, even though it happened much more, they were mostly underreported because the blame culture was very much evident. and people would not really take it for for example, if doctors were blamed that they were responsible for patient safety issues, they would not take it. Likewise, we have seen the case of Samuel Weiss, who advised hand hygiene, and even though he stated that doctors, medical interns who were coming from the autopsy and going to the maternity wards, and they were responsible for much of the maternal deaths, because of which he was rather blamed than the doctors, and invariably he also died out of sepsis. So that means that there were doctors or the senior professionals were truly guarded. They would not accept if some mistakes were happened, and they would always pinpoint the blame on the junior staffs, and that's how it was. And since because of this blame game culture, no one would have effectively look at reporting the errors, and this was something that was taken as an important learning for the next set of patient safety program. So the one of the roles of patient safety officer at that time was collecting and documenting incidents, doing a root cause analysis, and filing the report. So that was his job. Compliance to reporting, compliance to filing of the reports was one of the important aspect of patient safety officer. And as I said, success was measured by number of incidents reported, number of investigations completed, rather than learning from why these incidents particularly happened. The next slide. So even in the era between 2005 to 2012, errors kept getting reported. So, but there was a little change in culture, and one of the important aspects that they understood as contributing factors towards patient safety was the communication failures. Another important achievement in this particular era was the launch of WHO Surgical Safety Checklist in the year 2008, and then it markedly reduced the surgical complications globally. And it was successfully adopted across 193 countries within years. And it gave a very important lesson, especially in the patient safety program, that simple standardization can make a big impact. And especially, surgical checklist at that point of time was not just viewed as a bureaucratic tool. It was used, or it was seen more of a team culture, like a group of people who are performing surgery, right from a junior staff to the senior surgeon. They were involved in the surgery, and if there was something that could go wrong, the junior most person in the staff could can tell that, okay, this particular procedure was not done, and hence this cannot be ticked, and people would go back and probably comply to it, and thereby there was a reduction of sepsis and mortality and things like that. So one of the tasks that was given to the patient safety officer is to monitor this checklist, and over time, a lot of other checklists also grew up, like hand hygiene checklist, and we looked at having standardization of care, especially introduction of standard operating procedures, care bundles. Care bundles is another example where doctor, he introduced this concept of care bundles. Bundles are nothing but a short, activities that are happening in a very continuous manner. He introduced this concept of checklist to prevent, COTI or a CLAPSI bundle checklist was introduced, thereby a reduction of, the bloodstream, the central bloodstream infections were reduced. So, an activity of proper hand hygiene, proper cleaning of the site. So all this contributed to reduction of, the tool hospital acquired infection caused by CLAPSI insertion, central line insertions. So this was another important study. So that means there was a standardized way of doing things. People looked at what we can standardize, and thereby reduce the errors from happening. And in our country also, the NABH picked up the accreditation bodies, started getting familiar with the hospitals, and they also brought in certain standard operating procedures to be performed, and by way of which the whole patient safety program became more or less, organization wide. A lot of hospitals also adopted these patient safety programs. The next slide, please. So at this point of time, I would also like to, there were certain, important studies that were happening in the national health services in England, and what we can learn is that even though NHS had a very robust reporting system, they had committees and everything. What was another important thing that that teaches us is just reporting or incident reporting does not reduce incidents. What we have to learn is that, okay, what happens, why did this particular event happen, what is that we can do to prevent it is more important than just reporting. So reporting today should not become a just a it should not be a compliance, but should become a organization wide learning exercise. Only when it becomes learning, then only the errors can be prevented. Next, policies. Just by having policies and having a document management system in your organization does not mean that the culture is getting practiced. We to ensure that the good culture of safety should be inculcated all across, right from a housekeeping staff to the senior most surgeon, and everyone should abide by the organization wide policies. And a simple incident reporting, as I said, should move from a just a incident reporting to a complete incident management system. It should be a closed loop system. Whenever an incident gets reported, we just report it, and the indicators gets measured and we close it. Rather, what we mean by a closed loop system is when you look at a root cause analysis done, you understand whether it is a training failure, whether it is a policy failure, what was it, and then if a learning out of it is to be made, and a person who is responsible for the act has corrected, and the evidence is shown towards that learning effectiveness, is when the loop gets closed. So this is what the patient safety incident reporting form says. Right from incident reporting to incident management to incident closure, by way of ensuring an effective closed loop system, is what we are learning today, or what is being practiced today as part of the incident reporting system. The next one. So between 2010 to 2018, staff again, even in this particular era, as I said, the policies remained on papers. The staff were afraid to speak. The warning signs were normalized and ignored, and safety became more of a documentation exercise. So we have to understand that it was in this era also in India, the accreditation started picking up, and accreditation became more of a compliance tool than a performance tool. So a lot of checklist which was supposed to be designed to prevent errors became more of a tick list culture, and that is what happened. What was actually introduced with a good intention became more of a bureaucratic or a compliance exercise, rather than being a predictive or a preventive tool of action. So this is when they realized that not just focusing on just human individuals. We have to look at the whole system, and that's where the system thinking evolved from this particular era, where people looked at just cultures, the leadership frameworks, the team steps, and other models came up, and also the WHO Speak Up campaigns came up. So one of the important thing that we in this particular era was the what we call as the CUS. So where people were sufficiently empowered to say, okay, I am concerned, I am uncomfortable because it's a safety issue. So there were two-level checklists where in a team, if two people were not convinced that a particular procedure could go ahead, the senior had to listen to it. So these were some of the important lessons that the WHO Speak Up campaigns brought. And then again, team steps is another element that team strategies and steps to enhance performance and patient safety. The crew resource management, where people were empowered to speak about on safety issues. So these were some of the important lessons that were learned in this particular era. So one of the responsibility of the patient safety officer was he became more of an organizational influencer. So he had to look into whole things, and then a lot of other elements were also brought into here the human factor, intelligence was brought in. Okay, so they used to understand, we need to understand as to why at a given point of time an individual would do mistake. For example, was the staff burden at that particular point of time? Was it because of a cognitive overload? someone having multitasking. For example, in a ward, if a nurse has to do vital recording here, she has to do medication management, and she has to do other work. So there is a cognitive overload that gets built up, and this could be one of the reason for a patient safety incident from happening. So people looked at the humans factor engineering, and that's also one of the byproduct of that was system thinking came into effect. So system engineering approach to prevent errors also happened. For example, we can't insert an oxygen port to a nitrogen port. To prevent an error, by design, systems have been designed to prevent an error from happening. So these were some of the learnings of this era. So where they understood that there's no individual to be blamed, but it is more of a system thinking is how the whole design thinking started. And next slide, please. So one of the important learnings evolved over a period of time was, rather than looking at why incident happened, what was going right all this time. Incident map happening 1 in 100, but 99 times things go wrong. So we need to understand why things are going wrong rather than just looking why an error happened. So again, for failure mode effective analysis, an important tool that is looked at by a lot of accreditation bodies. So this is more of a proactive and a very predictive tool, where the team engages well before a process gets implemented. They look at where an error can happen, what is the severity at which an error can happen, and what is the detectability. And they also have controls in place to prevent these errors from happening. So tools like FMEA has brought in a different perspective into which how we look at process engineering, having controls in place and a preventing an error from happening. So again, safety hurdles is an important, briefing, debriefing, important activity that we all practice every day before the start of an OT, before the start of a procedure is an important activity. Though it's very simple, though it looks bureaucratic, but when we practice, it has proven results that it can prevent an error from happening. Again, process redesign. So a lot of times, hospitals redesign their trauma, redesign their laboratory spaces to prevent the clutter, because there is a natural if there is a barrier to a natural flow of doing things, errors are bound to happen. So people have started looking at process redesign, system thinking has brought in all these effects into place. And this is a new flavor and a perspective to the patient safety program altogether. Next slide, please. So WHO also has a very ambitious goal to achieve near zero harm by 2030. So we have to see whether it is an audacious goal or is an achievable goal. And they look at developing high reliability organization. Even if you looked at the NABH 6th edition standards or the JCI 8th edition standards, which many of the hospitals have started adopting, have moved away from a compliance culture to a proactive and a predictive culture. So especially if you look at a hospital acquired infection, some of the elements that they have brought about is what you have done to prevent an infection from happening, what you have done to prevent an error from happening. And hospitals also are encouraged to move away from a lagging indicator to a leading indicator. What I mean is, we were all outcome focused. So that means that we used to collect the indicators, how many hospital acquired infections are happening, how many fall rates were happening, and we were happy because this is what the assessors would ask, whether whether there was a spike and what action you took to prevent that from happening. But today, the accreditation bodies are looking at what we call as a leading indicators. They look at how many patients were screened for patient safety, and what is your hand hygiene compliance. So if your hand hygiene compliance is 70, say 60%, naturally your outcome will be a higher sepsis. So they're now looking at what are your process indicators, what have you done to strengthen your processes to prevent harm from happening. So, and then the clinical pathways are clearly laid out, which I know again accreditation bodies insist on adhering to this clinical processes, so there is less variation of care. Engagement of patient and family members are important. So when a patient gets discharged, how does he take care of his own? How is he managing his medicines? Does he really know what medicines to take at what period of time? Compliance to medications, All these things becomes essential when we also take the family into confidence. And then the healthcare worker education and training is an important activity. There is an ongoing training program that keeps happening to ensure that everyone is aware of the best practices that to be followed, and there is less variations in care and activities. The next slide, please. So most of the time we think that the patient safety and patient safety programs and everything is very expensive. But what is in reality is all it requires is some of an effort and leadership and the culture change to ensure that the patient safety program goes without much effort. So WHO checklist, as I said, it's a very simple tool. It does not require any technology. Likewise, frugal innovations like one's mobile-based incident reporting can ensure that the staffs have adequate resources to report incidents and also learn from these incidents. And it also becomes vital today, especially in the private healthcare sector. Why? Because today the PEs or the VCs, when they do due diligence, that they do look into the patient safety programs before they invest money. So any hospitals which are unsafe are likely to get less funding than hospital which has proper processes in place, and where the patient safety programs, the patient experience programs, the clinical excellence, all these things are there in place. So these are proven studies, like where the investment opportunities for hospitals which maintain a proper patient safety programs have a higher favorability among the investors. The next slide. So I'll just skip this because, just a drill down of what we have seen from the role of a patient safety officer, from an incident collector to compliance culture builder, a system architect to a safety intelligence leader. So this again, I think we can skip. We'll go to the next slide. So the era of the next, what is the role of patient safety officer going to be? So we were all taken by surprise by the role of AI. So today we are so used to using chat GPTs, the cloud and other things. Of course, there are also issues with that which we do not have to discuss today. But what we need to understand is that as the patient safety program has evolved over a period of time, there are a lot of learnings from in each era. As I said, human factor thinking, the system thinking has made a very big impact in terms of our understanding of why errors happening, and not just blame an individual, but look at the entire system. Make your systems foolproof. Make your systems able to detect errors and prevent an error from happening than looking at data or collecting reports. So, what does digitization actually do is that helps cut down the bureaucracy, helps cut down the time it takes to, prepare a report. See, much of the time the incidents gets underreported. It is because the whole process of time taken for collecting a report, preparing a report, everything is so Herculean, and most of the time it is the nurses, other junior staff who go and collect the report. But what you have a system is a mobile reporting system where there is a drop down menu. You're able to, much of the information of the patient comes by integrating with the HIS. You have a very a simple tool which can report what exactly it is, medication errors, why it happened. And it goes automatically. It goes to the patient safety officer, where he can look at the number of reports that gets reported per day. What is it? Who it has to be circulated to. Whether it is, if it's a medication safety officer, it goes to the clinical pharmacist. If it's a hospital acquired infection that gets reported, it goes to the infection preventionist. They do the root cause analysis, and whatever the learnings are there, it gets reported all across the organization. So the learning becomes much more effective. And someone at the top of the leadership, they get a daily dashboard of how safe is your system, how many incidents get reported, how many repeats, how many errors were actually, incidents were actually reported, repeated, what is the trend. So everything at the when the leadership gets a note of all these errors from happening, so there is a more of a strategic thinking, and more resources gets buy-in from the leadership also happens, so that they are able to earmark greater budget towards patient safety programs. So this is what digitalization can do. And can we go to the next slide? So we can skip this. we can skip this as well in the interest of time. So as I said, today the role of a patient safety officer has evolved from just a recorder of incident into a designer of safer system. And the next generation of patient safety officer will not merely investigate yesterday's incidents. They will anticipate tomorrow's risks. They'll cultivate organizational learning and help healthcare move from reactive safety to predictive safety. A typical JD of a hospital patient safety officer looks like how it is today to what it should look like going forward. As I said, key responsibilities will be learning responses to incidents, proactive FME and risk assessments, analyzing harm trends, generate safety intelligence, advise the board and executive leadership on risk, and integrate AI tools for predictive safety surveillance. And success metric will be more on how many um, errors were reduced over time and what is the organizational learning maturity score and the digital maturity score of the organization. So the gap, between what the JD is and what it is going to be is where we need to understand and fill up those skill sets. So these are my takeaway points. As I said, the patient safety program and the role of patient safety officer has evolved together. They are inseparable. Culture is important and not just compliance, and this is what determines the patient safety. The lower middle income countries and India have contributed, towards global lessons. And what is required today is to have a proper national framework to detect incidents, errors, and devise our own India-specific policies to prevent errors from happening. And as I said, the role of a patient safety officer who's going to be the next will be more of a safety intelligence leader. He will have all the digital inputs in place. So what it requires is just more a shift towards EMR to having a proper intelligence systems in place, like we call as a quality management system or a hospital acquired hospital surveillance system is required. So this isn't just about my talk today. And once again, I thank both the Department of AIIMS, Department of Hospital Administration AIIMS, and the WHO SEA regional office for giving me an opportunity. So if I have any questions, I can take, or otherwise we can close.
Volume. Okay, thank you, Dr. Arun, so much for the thought provoking presentation and for highlighting the evolving role of the patient safety officer in creating safer healthcare systems. Our next speaker needs little to no introduction at all. We are honored to have with us Dr. Ramesh Agarwal, who's the professor of pediatrics and the head of division of neonatology at AIIMS New Delhi. He is also the director of the WHO Collaborating Center for Newborn Health. Dr. Agarwal is a renowned clinician scientist. He's a founder of the Indian Neonatal Sepsis Research Network and has authored over 300 plus publications with an H index of over 54. He is an associate editor and has held multiple seminars in the field of fetal and neonatal medicine. He's passionate about advancing perinatal and newborn survival through high value care and stronger health systems. Sir is equally passionate about the evolving role of patient safety and taking the cause of patient safety forward. He will be speaking on principles of incident reporting systems and taxonomies. Sir, this floor is all yours.
Thank you, Dr. Kanika, and let me share my presentation. I hope this is visible.
Yes, sir.
Visible?
Not the presentation, sir. We can see your screen.
Oh. Now?
Yes, sir. Now it's visible.
Right. Okay. So, good afternoon, everyone, and thank you very much, Dr. Kanika, WHO team, for this wonderful opportunity. In next 20 minutes or so, we are going to talk about incident reporting and the common language that we should be using. Um, this has been why it is important, and a lot of data has been shown by Dr. Shah, and I need not go again on the through these numbers. But what is very important is that it's an important preventable cause of death and disability. In fact, it has joined the leagues of major killers if you look at our population-based data. So therefore, this is absolutely very, very important, and it's a preventable cause of death and disability. That makes it even more important, and rightly so. The WHO has launched Global Patient Safety Action Plan 21 to 2030. The errors or harm have got its own science. It's not random at all. And if you look at the data, whether that's high income countries or the low income countries, there is striking similarities. The harm happens in form of medication errors, healthcare associated infection with very high case fatality rate, diagnostic errors, sorry, diagnostic errors, surgical and procedural harm, false identification issues, and unsafe systems and staffing. As Dr. Arun alluded to the fact that most of them are tied to weak systems and not bad people, and that's a very, very important principle that we need to know. So now let me take you through this story. So this is NICU 2 a.m. in the night, and 1.4 kg baby needs adrenaline. The resident calculates the dose as 2.0 milligram to be dissolved and prepared an infusion, but the nurse reads it as 20 milligram, misses the decimal point, and prepares the infusion. Fortunately, before the administration, the nurse looks at the 20 milligram figure and did not make any sense, and she stops before it reaches to the baby. So the harm was prevented, but it was a near miss. I'll pause here and then ask this question to you. Will your people report it? If the answer is maybe not, the system never learns. I think this is something which is very, very important. And underreporting is the norm, then the rule. Even the best of the systems, only 7 to 15% of the reports the incidents gets reported, and the rest of them goes unnoticed. And this is not staff's failing. It is a signal about the culture and the systems around them. Why people stay silent, and that's really very, very important. One is blame, the fear of being named, punished, or shamed. The fear about worrying about the juniors, seniors, and medical legal fallout, and that's a big one. People don't have time, and also very important that uh, the people see that nothing changes. So therefore, what's the use of giving feedback if nothing changes? So it is really very important to realize that the reporting is not just a paperwork. The incident report has got two very important purposes, and of course, everything else is managing those two real jobs. One is making risks visible. So you surface the hazards and the weak points that your staff can see, but the system cannot. The second is the preventing harm, which means turn this visibility into action that protects the next baby or the next patient. The honest tension lies in the fact that the reports are often used to blame an account. And when that happens, the people stop reporting. When we use them to learn, then the reporting grows. And we cannot maximize both at once. We need to prioritize learning part. So this is the cycle from incident happening to the action. So what are the steps? The steps are that when you have an error or a harm, the first thing is to recognize, and the first and foremost, the thing that you need to do is to contain that, so that the harm can be minimized or prevented or managed if it has happened. So that is the first step. The second step is record and report. The third step is analyze it. Analysis happens by the local team, and analysis happens by an expert team. And then you identify the corrective and preventive action, and you act. And you act such that the system change so that it cannot recur. It's very important to keep learning, so therefore when you analyze many reports, you get to the root cause of the problems and the fallacies that are there in the system that can be prevented to prevent harm to the future patients. So this is a pyramid, and you can see that at the base, you have incidents that is reported. Then the report is assessed, the causal investigation is done, that gives us systems insight, and action is planned and implemented, and that's how the future harm is prevented. The value only rises when we move from the base to the top. Unfortunately, many systems work hard at the base, collecting the reports, and stop there. But the value to the patients only appears as you climb up. So collecting reports is not learning. That's very, very important, because you can keep counting. You can keep filling the forms and keep telling them. You can keep counting the numbers and keep making the charts and keep calculating the report. But the incidents keep recurring. And Dr. Arun took us through that journey of 25 years, that they kept recurring, and we have come a long way. The important is that we learn. We learn from the harms that have happened. And team actively changes what it has been doing. The practices and processes are adapted so that the system improves. And just collecting data is not improvement, but data-driven action is actually an improvement. So coming back to our NICU example, there is what is known as Swiss cheese model. Swiss cheese model, what it says that you have several differences where a harm can reach to the patient. And when you have one difference breached, you may have second one that might prevent it. And then when the second is also breached, the third might prevent, and so on and so forth. It's only that all the differences break, the harm reaches to the patient. So here, the prescription error was there. 2 was read as 2.0 read as 20. Then the nurse was preparing medication. Again, that difference got breached. And then the third person, when it came to the administration, someone noticed it, and that the harm was prevented. So it was a harm that did not reach to the patient. That's known as near miss. Here, what is very important to remember is it is not those who blundered. That's not at all important. It's how and why the differences failed. That is more important for us to examine and understand. This is something which is critical, which lies at the heart of incident reporting, and that is, do not kill the messengers. So the ones that are reporting are not at fault. It's the system that is at fault. So what should happen? There should not be any blame, any punishment. And you read news and unwritten, unreported, the providers are blamed and punished and suspended and whatnot. In fact, they are encouraged and valued. And in our hurdles, we often say the ones who report incident, that's the most selfless act of welfare. Third important thing is close the loop. So someone has provided, reported an incident. If we do not provide feedback that this is what has happened to your report, this is what we understood, and this is what we changed, then it starts dying. The process starts dying, and you need leadership commitment, time, policy, and practical steps. And you need to change the practice. This is what counts. It's not just a poster on the wall. So coming back to our topic, that what is actually a patient safety incident, and it's a very inclusive report. To put it very plainly, an incident is anything that did or could harm a patient. Did or could harm. It is not just something bad, something went bad wrongly, but also a near miss, a no harm slip, or even an unsafe condition that you might have witnessed. All of them are incidents. So report these incidents when a patient is harmed, even mildly. A patient that could have been harmed, like our NICU patient, or you spot an unsafe condition. You see that the floor is slippery and someone can fall. An equipment that is failed, or a step is missed, or a process is broken, or you simply are not sure, just report it. Coming to the taxonomy is nothing but a shared language, so that a nurse in Delhi and a doctor in Chennai mean the same thing. So the reports can be analyzed in a standardized format, can be compared, and we can learn. And we just saw that the incident can happen in many forms. There could be near miss, a harm happened but did not, incident happened, but the harm did not happen because it did not reach the patient. It reached to the patient, but the patient was not harmed. So that becomes a no harm incident, or it could be a harmful incident, and harm could be mild, moderate, severe, or even a death. So the purpose of reporting is just these three purposes. One, what happened? Provide description. Who was the patient? What was the incident? What was the type of incidents? When did it happen? Where did it happen? The second point is, why did it happen? So what were the contributing factors? What made harm less or more? And what it made likely. Third is, what was done? The remedial measures that were taken, immediate response, and then changes were made so that it does not recur. We have what is known as WHO MIMPS, Minimum Information Model of Patient Safety. This is the basic set of just 8 data categories, and that is enough to begin with. And of course, you should always have a free text form. There are simple, when you wish to report, then there are simple 7 steps. First is, and this is reiteration of what I have said earlier, the first is what happens bedside. That you notice a harm, first make the patient safe and tell the colleague or a senior on duty. If you think that the harm is a serious one, say it aloud. And it's the system's duty to make sure that you feel psychologically safe enough. 2, put it on the record, fill the form and submit it. There are various ways of doing it depending upon the system. It could be a paper piece, or a WhatsApp message, or a QR code, or a box. And anonymity would be very important. If the person wants to remain anonymous, then that option should always be available, and it should come back to you. Acknowledged, a thanks note that you reported, and the serious event is reviewed in 24 to 48 hours, and feedback is provided. So it is kept simple. There should not be any jargon. There should not be any blame. This is one example, the form that we have designed. This can be used. This is just an illustrative, taking those 8 fields that you have in WHO MIM format, and you can adapt to this unit, to your unit. Most importantly, keep it human. Paper or electronic, there should always be free text, because the structured text only captures so much. Anonymous option should be there, and it should take only 2 minutes, not 20. And important that the same form should be used for near misses as well, because the near misses are something that is kind of free to learn. In your context, start where you are. Don't wait don't wait to be perfect. In low resource setting, the temptation is to wait for IT system, staff, or budget. And the WHO's message is explicit. Do not abandon the idea, start small and build the culture first. Start with one simple paper or phone call or a phone form, a safe and no blame way to submit. There must be a small team that reviews the incidents on a regular fashion. There should be one change made and feedback provided to the reporter, and near misses should always be included. These are some of the traps that you should avoid. One, swamping the system, collecting too many, no feedback provided, blame, that's the biggest one. Avoid blame, encourage people, praise people. Counting report is useless. If that's the goal, don't do it. And waiting for the perfect system to happen. So summarizing the whole thing on this one slide, that it is about culture. It has to be safe. People should feel safe. There should not be any blame. They should be valued for what they are doing. Keep a simple format with 3 purpose, as simple as possible. Use a shared language, do a local analysis, take action, and provide feedback. A system that turns honest report into prevented harm is far important than the perfect system. So 5 carry home messages. 1, unsafe care is a major preventable form of harm. Underreporting is the norm, and the cause is culture, not bad staff. Third is, don't kill the messenger. Psychological safety is the foundation. Keep the format simple, use a shared language, and don't worry about a perfect system. And just don't count, but act. Learn and act. I stop there. Thank you very much.
Thank you so much, sir. Thank you, Dr. Ramesh, for the comprehensive presentation that we have. And I would now like to invite our next speaker, who joins us all the way from Singapore. It is my pleasure to introduce Dr. Alvin S.M. Chang, who is the Director of Quality, Safety, and Risk Management and is a Senior Consultant in Neonatology at KK Women's and Children's Hospital, Singapore. Dr. Chang is a recognized leader in healthcare quality and patient safety and has played a key role in Singapore's high reliability healthcare initiatives. He is also a faculty member of the Singh Health Institute for Patient Safety and Quality and is an educator in patient safety, quality improvement, and teamwork programs. He is the former president, Healthcare Quality Society of Singapore from 2019 to 2023, and is the current president of the Singapore Pediatric Society. He's a widely published author and a recognized expert in patient safety, quality improvement, and neonatal healthcare. He's committed to advancing safer healthcare systems through quality improvement, learning from incidents, and high reliability practices. So, who better than Dr. Chang to really speak on the topic of learning from errors, from reporting to root cause analysis and corrective actions? And Sir will also be highlighting how to build a reporting and learning culture through leadership, feedback, and non punitive responses. Dr. Chang, we are delighted to have you with us. Over to you, sir.
Thank you. Thank you for the kind invitation again, and also for WHO Southeast Asia Regional Office to coordinate this meeting today. Let me just go to my slides. Okay. Right. Right. I am very heartened to actually hear the talks from both Dr. Arun and Dr. Ramesh, because many of the things that I'm going to dwell into here, there will be quite a number of overlaps. Um, I think center to it is the key word here that we are talking now is about the systems, the culture, and how do we actually support our people, from doing the right thing, and also how do we support people who put up incident reports. And so I think we should come, particularly as leaders, we should come from the premise that errors are common, yeah, in healthcare. And I do not think that, you know, whatever industry that we work in, we can avoid errors completely. Even the airline industry, they do have their fair share of errors. The nuclear powered industry, they do have their fair share of errors. But what's more important is um, learning from these errors, making ourselves better. And one of the key things that we talk about is reliability. That means, you know, people doing well established processes, working with well established processes, irrespective of the time of the day, irrespective of whether they are being looked at, whether they are being audited, whether they are being supervised. If everyone can practice things in a standardized manner, well, that's one way how we can actually reach our goals, with trying to achieve zero harm. And there are a lot of elements to think about it, and we know very well and we need to also convince the junior most doctor, the junior most nurse on the ground, that harm arises from gaps in the system. Um, Often when we preach to them about systems, being someone new to the organization, the biggest challenge that we face is different people interpret the systems differently, but if you go I mean from its very simplistic manner, system just simply means the interactions between the people and the processes that they created, between the people and the equipment that we have provided them to work with, between the people and the policies and procedures we as hospital leaders have created for them. That is the system, yeah. You know, being a neonatologist myself also, we have multiple systems. Yeah, we're dealing with children. They're high. They're higher in terms of vulnerability. Okay, weight-based dosing was one of the key things. That we talk about, and this is where the risk of errors are usually very high. If we do not support, if the system does not support people in preventing calculation errors from happening. So at the end of it, the goal is to reduce harm. Our people need to understand it is just not about blame. Dr. Ramesh Agarwal talked about the Swiss cheese model, and this is another way of looking at it. If you imagine each layer of the cheese as perhaps the patient's journey from one angle, or you can even look at each layer of the Swiss cheese as different aspects that provide care. Okay, one layer may be the people working in the system. The second layer may be the tools, our equipment, The third layer would be supervisory framework. The fourth layer may be, whatever organizational policy that's been in place. We need to always come from the angle that whatever we put in place, there
Dr.
are
Alvin,
effects.
sorry to interrupt, but your slides are not changing and it's not slide show mode. So
You
maybe
have to go to slideshow.
I'm already actually in slideshow.
Then you click on each one. There is a presentation problem. Yeah. Then each slide you need to click to get it to the main frame.
Are you seeing the Swiss cheese model now from this
Yeah,
slide?
yeah.
now.
You are in the slide 3. Yes, now. Yeah.
Yeah.
Maybe you can try once more, then it might work.
Yeah.
No, I think for that he has to get out completely close and go again. I think this is okay. This is visible.
You're
But
still seeing
you have to
this
click
model?
on each slide separately every time. Then.
Okay. Right. Then what I'll do is, okay. So so as I said earlier, the Swiss cheese model, what happens is at every layer of the Swiss cheese there are defects. The problem is when these defects align with each other, that's when an adverse event will happen. And so the whole purpose of incident reporting and analysis of the incident is to try our best to close as many gaps as possible. It will be impossible to close every single gap, within our system, and trying to plug as many gaps as possible is where we can make the care safer. So I'm glad that Dr. Ramesh actually talked about the taxonomy. So these are some of the things, some of the terms that we use. Incident reporting should include both adverse events and even the near misses. Near misses really, really will provide very high learning value because to a certain extent, it is like what we talk about, what Dr. The one of the previous speakers talk about, like it's just like a failure mode effects analysis. Things have not happened, but there are signals to tell us, something disastrous may happen. So really, we shouldn't only be focused about what went wrong, but we should also be focusing on what nearly went wrong and do an analysis around it because this really forms the foundation of safety systems. And as leaders, these are the barriers we need to acknowledge. Someone who just started work, in the healthcare industry, there will always be fear of blame. There will always be fear of punishment. As leaders, our role should be actually trying to convince them, trying to tell them, look here, every report that you put in is what we want. Yeah, every report you put in really helps us, to improve the system. Reports are not meant to be for punishment, and reports are not meant, to be punitive. And of course, lack of time is often one of the key things. And it is because of lack of time, sometimes the quality of the reports are affected. So really, making reporting easy is key. Making reporting, not burdensome would be very important. And again, whoever reports need to have a close look in the communication. Yeah, there's always the general perception. There's no point in reporting because nothing changes, nothing improves. So that is a perception that needs to change. And so, what really good systems do is number one, we should have a non-punitive culture. In fact, within Singapore, there was at one period of time where our leaders, including the ministers of health, they were of the opinion that if the culture is good, we should have less reports, less incident reports. Well, I feel that that is a very dangerous concept to take about, because if we get lesser reports, it may be indicative a punitive culture could have actually crept into the system. In fact, if you were to have a good safety culture, we should see more and more people reporting incidents in and more people, should be reporting near misses. And so really, there is a balance to make a blanket statement saying that, if the safety culture has improved, we should see lesser reports. Really, I don't think we should be looking at that. In fact, I would challenge organizations by saying that if your safety culture has improved, you should see more near misses compared with actual incidents. Yeah. Making reporting systems simple and ensure feedback is given back to the front line would be important. And so when we conduct a root cause analysis, these are the key questions. Okay. We need to know what happened. And to know what happened really involves also a skill at how we dig information. Is it going to be an interrogation, or is it going to be a conversation, you know, convincing people to be transparent, to be honest? Because if the interviews are conducted, in an interrogative manner, you really get nothing out of it. Yeah. What we want to understand is not just about, um, you know, the error happening. We also want to understand the circumstances around the error. Why did it happen? Was it a busy day? Was it an increased workload? Was it, a surge of admissions that came into the inpatient area? Was there inadequate equipment? Was there, understaffing, and so on and so forth? And this is where how we can identify what really contributed to the error and to prevent further recurrence in future. I'll take this case as an example. A 3-year-old with pneumonia, admitted and prescribed intravenous gentamicin. Um, the dose was calculated incorrectly. It was 10 times. This child was 10 times overdosed, the dose of gentamicin. Unfortunately, the error was detected after 2 doses of gentamicin was given and required ICU monitoring. Um, you know, because there's always the risk of nephrotoxicity and on a longer term, ototoxicity. So, was this an individual mistake or a system failure? That should be the key thing that we need to ask, you see. And when the case analysis was taken up, a few things actually surfaced. The weight was not documented clearly. Perhaps the handwriting was illegible. Dose of drugs was calculated manually. And there was no independent double checks. Just before the dose of drug, before gentamicin was injected into the child, charts were looking alike, just a standard chart with all the list of medication, with a lot of information in there. That itself is a human factor, of not of not ensuring people do the right thing. And of course, it is very common, that we work in a very high workload environment. And so, how do we put this all together? How do we consolidate this? To really look hard into the system. And so, this is where I want to just introduce to everyone here what we call the HFACS tool, which stands for the Human Factors Analysis Classification System. This is available on the internet. You can actually look for it. Yeah, it's by James Reason himself. So to assist case analysis, to really dive into the system, um, James Reason feels that, first of all, let's ask ourselves, what was the unsafe act? Was it an error or was it a violation? If it is an error, was it a decision-based error, skill-based error, or perceptual errors? Yeah. Okay. So the review panel, should be able to identify from here. Now, if you look at the other side of the Unsafe Act, they talk about violations. The intent here is not to punish people. Okay, the intent here is to highlight, particularly if it is a routine violation, it just means that when we conduct the RCA or the root cause analysis, we shouldn't only be interviewing the staff who was involved in the error, we should be interviewing all her other colleagues, as many people as possible. Because if that particular staff who perhaps took shortcuts resulted in an error, we also need to establish whether she is the only one who did it. If there are other people in that department who are actually doing the same thing, but the rest were lucky, no patient harm happened, that is a routine violation. Yeah. And what does routine violation simply just means, Perhaps our policies are too onerous, that people are taking shortcuts. That is a system. That is what leadership should take, should really, put in a change. Okay. If it is not just one individual, but several individuals in the department are not doing things in accordance with what was established, then really it is a leadership thing that leadership needs to, look at themselves and ask themselves whether whatever systems I've created is making life more miserable for the person on the ground. Okay. Now, once we have identified the unsafe act, we move up the second tier, which is preconditions for the unsafe act. So at this second tier, then we actually ask, what were all these conditions that contributed to the unsafe act? Was it situational factors? Was it a very poor, cluttered physical environment that my doctors are working at? Was it is it that we did not provide people, proper tools? Yeah. Did we not provide people with, particularly in pediatrics, when we calculate, weight-based dosing? Has the hospital at least provided calculators by the bedside for people to use? Or is it, a requirement that all doctors need to bring their own calculator? So what happens if on the day, it just so happened on the day when this particular doctor came to work, the calculator went out of battery? What's going to happen? So these are the little things. That's what we call systems. You see, yeah. Was there any conditions of the operator that resulted in the unsafe act? The mental state of the individual. Did the individual come to work with a divorce at the back of his or her mind? Did the individual come to work with a child who is sick at home? And is it really right to punish such individuals? Yeah. So looking at physiological states, physical and mental limitations, disabilities and so on amongst our staff is also another way that organizations should look into. Were there personnel factors? That means problems with communication, coordination and planning, or even fitness for duty, that contributed to the unsafe acts at the bottom. And so once the preconditions of unsafe acts, it can be one factor, it can be more than one factor, then we need to go up. Were there supervisory factors that led to preconditions of this unsafe act? Was supervision adequate? In fact, if I would have identified a routine violation at the bottom, immediately my mind will go towards supervision. Okay. Was the supervisors, was the head of department or the head nurse in that particular ward or that particular department, is he or she aware that the staff are all taking shortcuts? So what was the level of supervision there? Plan inappropriate operations. Okay. A sudden surge of admissions. What is the interim plan when such things happen? Do the supervisors know what to do? Yeah. Failure to correct a known problem, or even was there problems with supervisory violation? Now, the intent is not to penalize or to make a witch hunt of the supervisors when we go to this third level. In fact, we now go to the top. We now need to ask the people at the top, senior management of the hospitals, okay, what were the factors at the senior management level, that could have inadequately supported the supervisors in their work? Okay, was it a cultural thing? Were supervisors, been looked at as incompetent if they keep going to senior management for problems? Yeah. Is it an operational process thing? Our policies, our procedures, that make our supervisors work within really very difficult constraints, or resource management? Resource management could be, equipment. It could be uh, uh, the medications, yeah, financial budgets, and so on and so forth. And so at the end of it, we keep telling people, for every incident report that we describe, we expect people to analyze this in accordance with this broad 4 tiers, and we want to see, factors identified at the organizational level. We do not want people to stop their analysis, just at the level of preconditions of the Unsafe Act, and that's it. So conversations, if you use this HFACTS tool as a guide, conversations will generally become a bit more deeper. It will be more value will be added. Yeah. And of course, as a result of this, you'll be able to come up, with more concrete, more system level kind of recommendations. So coming back to that case, you see, so the Unsafe Act was actually the dosing error, and what led to this dosing error perhaps was the workload and the illegible writing of the weight, the documentation of the weight. Okay, at the supervision level, we actually found out, you see, that there was no double checks, prior to administering an intravenous medication. Okay, it was only done by one nurse. Okay, there was no mechanism that was created, by the organization to have a double check of medicines, before you actually inject it into the patient. And of course, um, at the organization level, there's no standard dosing tools. Yeah, well, it can be as simple as a calculator, or it can also be as simple as, now that a lot of organizations are going electronic. Okay, so where are the tools to help the people on the ground at 3 a.m. in the morning, when they have to scramble to resuscitate patients and do a lot of other things. Yeah. Okay. And when we come up with improvement plans, I deliberately showed this. If you look this at the bottom, the simplest thing that everyone tends to do is, well, we will strengthen our educational activity, we will strengthen our training activity, we will tighten rules, we will introduce policies. Okay, now I think you need to bear in mind, education, training, rules, policy is still very human factor dependent. You still rely on the human memory, to be able to do this. Okay, but at 3 a.m. in the morning, our brains all fail. That's the reality. Whether it's the high flying doctor, or a new doctor who come in, who just started work. Okay, really physiologically, this won't really work. Therefore, what this chart is trying to allude to, when we come up with improvement plans, we should go by trying to improve the system rather than adding on cognitive workload, to our people on the ground. Checklists is one thing, which is actually better than making more rules, but checklists can just be can simply turn out to be another charting exercise. Yeah. Relooking at the processes, relooking at the policies, for avenues of simplification, for avenues of standardization would be important. Automation is something that, and tapping on IT is will be useful. Yeah, that means we ensure people do the right thing all the time, and of course forcing functions. And I must say, going with automation and forcing functions are not easy. Yeah, you really require multidisciplinary input. You need input from your IT engineers, you need input from the doctors, you need input from the nurses. Really it is a multidisciplinary affair that we have to put in, and that is the kind of work that involves changing the system, which is going to be more effective. Okay, so again, this is just to summarize what I've said earlier. The focus is on system redesign. So, and of course, it's important to close the loop. Yeah, assign responsibility. Who is going to take this recommendation? Who is going to improve? who will be the lead for the improve, monitoring compliance, auditing outcome, and the important feedback staff wants to hear is you reported, we acted. Okay, so reporting is just the start, of everything. Errors are system driven. Root cause analysis must go deeper than just the human error. And strong action plans addressing systems or addressing factors at the organizational level will prevent harm, on a longer term basis. Okay, thank you. Um, should I continue with my next talk, or do you want to have
Yes, sir.
a continue? Okay. And
No,
so,
no, sir. Yes.
yeah. And so, that is what we would like people on the ground do. My other talk here is about, mainly targeted at the leadership level now, building a reporting and learning culture, looking at leadership feedback and how can we actually encourage, non-punitive responses. Now, I think this is a very common scenario. Okay, a nurse notices a potential harm may happen. Being a nurse, she hesitates to speak up, and the error reaches the patient. Yeah, I think it's very common. Don't talk about nurses. You can talk even about our allied health professionals. Yeah. A pharmacy might have noticed an error in the prescription, but hesitate to raise because perhaps the prescriber is a senior most person with a good track record. At the end of it, it is the patient who suffers the harm. And so this is really about culture. And we know very well, the saying, culture, whatever culture we develop, um, it really is important to ensure that our staff are able to report freely without being penalized. Okay. We also need to ensure that our staff are given, the freedom to be able to speak up and to raise concerns. And more importantly, we need, as leaders, our mindset should also change. The errors are used for learning. We shouldn't be using errors to punish our people. Yeah. In fact, I will also add on by saying, if you want the culture to improve, the person who has spoken up to you, you being the senior most person, okay, if the error actually didn't happen, yeah, or even if the individual who has spoken up to you turned out to be wrong, it is the responsibility of the senior individual to thank the person who raised the concern. Okay. So this is something that we also tell our people in Singapore, when people raise concerns, do not always expect the harm to happen or the harm could have been avoided. There may be times when they are wrong in their judgment because they've just entered the industry, their experience is less. But that's okay, Rather than putting them off, rather than, uttering certain demeaning words to them, why don't we thank them? Do it the other way around. Because the next time, this individual could potentially prevent us as senior people from going to court. Yeah. So I'm going to touch on these three key elements under the leadership talk here: psychological safety, speaking up, and civility, respectfulness, between colleagues, professional respect at the workplace. We know very well speaking up for safety prevents harm. Um, it is really, a real-time defense uh, in our industry, and it is inhibited by fear. Now, if you look at the high reliability industries, the airline industries, the nuclear power industries, they are much safer than us. They are much reliable than us. They've learned from their mistakes. You know, that really, it is not just about the captain who's in front there driving the plane, who's the greatest person, but every single person, every single crew, concerns raised by the crew matters. So they've gone up to that level. They've gone up to the level of listening to people. And so these are the reasons why people don't speak up, because of hierarchy. Sadly, unfortunately, hierarchy will still exist in the healthcare industry. Yeah, there will always be hospital leadership, middle managers like head of departments, and so on and so forth. Yeah, but it is, although the hierarchy is what our human resource and organization chart wants us to look at, but it is the dynamics. The team dynamics is more important. How the leader actually portrays himself or herself to the staff members. How can we actually break hierarchical barriers at a functional level rather than just referring to it in the organization chart? Past negative experience, as I've alluded to earlier, is important to avoid, even if the person who raised concern was wrong. So this came from the Joint Commission International, and they've actually stated, 80% of serious safety events occur due to miscommunications. Among healthcare professionals, speaking up is one of the critical behaviors of patient safety and is an important role for improving quality and patient safety in healthcare. So, now there is the other aspect of what we also encounter, our juniors will encounter, interprofessional civility. Yeah. A junior nurse questions a high dose of insulin. The senior responds dismissively. You know. So the key thing here is the senior actually responded in an unprofessional manner. So the nurse hesitates to re-challenge and just administer the dose, administer the drug. Wrong dose was given. Patient develops hypoglycemia. Okay. So again, this dwells into psychological safety. Is it safe to ask? Is it safe to challenge? Is it safe to raise concerns? Or even, is it safe for me to admit my mistakes? A lot of this, if we don't take into account, I think the safety culture will never improve. So leaders, the role of leaders is important, yeah, because I think leaders should always look at inviting input, yeah, raising concerns, thank people for speaking up, and it's important for the seniors, to model humility. This is the model that we are now that our hospital has been working on in the last 15 years. Two ways of engaging our people: top down management, yeah, to set the tone, to walk the talk, and so on and so forth. But at the same time, we have avenues, for people to raise concerns. So there's also the other bottom up management. And when people raise concerns, it should be taken seriously. It is, as what has been alluded to earlier. It's just not another data collection exercise. When people raise concerns, when people raise feedback, uh, it's important for the leaders to look into it and to put it into action. Of course, I also do admit we do have a fair share of, concerns being raised, but really we can't do anything about it. Even if you can't do anything about it, it will always be good to close the loop in communication to the individuals or the departments who have raised the concern and state explicitly the reasons why this could not be done. Just wanted to show you, the vicious and virtuous cycles of psychological danger and psychological safety, respectively. If there's fear of admitting mistakes, there will always be a blame culture. People were less likely to share different views, and it becomes a common knowledge effect. Meaning to say, my colleague has been penalized for admitting mistakes. Okay, I will not raise concerns if I happen to commit the next mistakes in future. Versus if people are comfortable admitting mistakes, they learn from the failures, everyone openly shares, this can lead to better innovation and decision making. And so, again, this ties in together with civility and respect. The way how we talk to our people, being uncivil really will suppress the voice of the individuals, it will lead to harm, you know. And respecting each other irrespective of the professional groups, the skill sets of the different professional groups itself is a safety tool. um, these are some of the tips that we tell people, you know. Ask what happened, avoid blame, you know. And the key thing is both the mindsets of the person who's asking and the person who is reporting the mistakes, you know, is both need to be aligned to know that this the focus is on learning. And so this is where what we call the just culture is. Yeah, every human error that we found out, of course we console. If an individual does something at a risk that is not recognized, we need to coach the individual. And of course, it is still within the just culture framework. You know, if we found individuals deliberately want to harm patients, reckless behavior, then we will punish them. Yeah. So I think the just culture framework should not be viewed as, you know, we don't punish people. We do punish people. Okay, if for example they come to work under the influence of alcohol, you know, or they come to work under the influence of drugs and so on and so forth. So it is within the just culture framework to discipline this group of people. But the just culture framework also looks at, you know, systematically analyze the incident. You know, have we covered all other grounds within the system before we actually blame the individual? And these are the principles behind what the just culture is. What is the organization's values? What are the organization's expectations? Has it been stated clearly, you know, to the staff? And based on these values, you know, what has the organization put in the system designs to ensure that our people make the right choices? Yeah, make the correct choices when they carry out their work. Have the organization also created learning system? Only then a just and accountable culture can be created. And when we when and you know, the way how I see accountability is not just about accountability on our staff, the people who deals with the patient, the people who's in the front line. It should be shared accountability. That means senior management must also be accountable for their action. Senior management is the custodian of the system. So shared accountability would just mean senior management and frontline staff, you know, making decisions to create a learning system and to create a more reliable way of working. Okay, so I think incivility leads to silence. This leads to harm. Speaking up depends on how leaders respond. One negative interaction can suppress future voices. Psychological safety is built moment to moment. Respectful responses can prevent harm. I think every leadership response shapes culture. Every time a leader responds to an error, they are not just managing an incident, they are shaping the culture for the next 100 incidents that may crop up in the organization. Thank you.
Thank you so much, Dr. Alvin, for the presentation. It was extremely lucid, and thank you for sharing your valuable experience and practical insights on transforming incidents into opportunities for learning and systems improvement. And also, we are highly grateful to you for sharing Singapore's experience in the field of patient safety. Now, before I'd like the next speaker that I would like to call is a colleague of mine from the Department of Hospital Administration. So, may I request to call upon Dr. Nishant Sharma, who's the Assistant Professor in the Department of Hospital Administration, AIIMS, New Delhi. Nishant is a healthcare management professional with expertise in hospital administration and quality improvement. He's actively involved in teaching, research, capacity building of healthcare professionals in quality and patient safety. He's a contributor to the national and international initiatives on patient safety, healthcare quality, accreditation, and health system strengthening. He's experienced in designing and implementing various quality improvement projects, patient safety programs, and healthcare management training. He is also trained facilitator for the JCI Training of Trainers program. He's a published researcher and speaker on healthcare quality, patient safety, and hospital management. May I ask Dr. Chan to give the closing remarks and the closing presentation on how we plan to take the webinar series forward? Over to you, Nishant.
Thank you, ma'am. Thank you all. Good afternoon, good evening from India. And I hope my screen is visible and I'm audible. As we come to the closing of the second regional webinar, and the theme for today, although very basic, but it lays the foundation for any patient safety program that we run in our organizations or in the country. And as so today's webinar, we had our first session by Dr. Arun, who talked about the development of a patient safety program for an organization and the roles that a patient safety officer needs to play. And this was followed by Dr. Ramesh Agarwal, who talked about the principles of incident reporting systems and taxonomies. And Dr. Alwyn, he talked about learning from the errors and also shared institutional case studies. So before I go into the highlights of today's webinar, I would like to thank our patrons and mentors, Professor M. Srinivas, Honorable Member of the Niti Aayog and former Director of AIIMS New Delhi, and Dr. Aparna Singh Shah, who's Regional Advisor, World Health Organization SEARO region. The organizers, AIIMS Patient Safety and Quality Cell and the World Health Organization SEARO, our eminent speakers for today, and most importantly, all the participants who have join this webinar and have the commitment to the patient safety to take it to every organization that they are affiliated with. So Dr. Arun outlined the foundation steps for developing a robust patient safety program. He emphasized the critical role that dedicated patient safety officers play in today's scenario in institutional excellence and coordinating comprehensive safety initiatives across departments. He also talked about the changing scenario of patient safety over the previous decades and how the role has been modified. Dr. Ramesh talked about systematically decoding the principles underlying effective incident reporting and highlighted the necessity of utilizing standard taxonomies to ensure that the data is categorized accurately, interpreted adequately, and ultimately preventive actions are taken to prevent recurrent clinical incidents. Also, Dr. Alwyn, he stressed on the importance of transitioning from mere reporting to active learning and emphasized that reporting an incident is the first step. The true value lies in how we learn from it and the critical importance of designing and implementing sustainable corrective actions. He also shared experiences from Singapore that help us better understand that how a better, a just culture or an environment where the staff is free to speak up leads to better patient outcomes and a safer healthcare. So everybody emphasized that we need to take the incidents that are reported to conclusive evidence. So I thought that the phase one would be reporting of incidents followed by a root cause analysis, then sustainable and corrective actions, the actions that are sustainable and embedded into the system, which will eventually lead to safer patient care. And to sum up the synthesis, what I thought is structure is the key, standard taxonomies and clear program structures, which have to be led by dedicated patient safety officers. They are non-negotiable for identifying latent risks in our systems. Also, analysis of the data is very important. Collecting reports is insufficient. We have been doing it for decades altogether. But the true value lies in deep root cause analysis that leads to actionable and sustained interventions, and a just culture which is driven by leadership. As Dr. Alwyn mentioned in a couple of his slides, offering psychological safety and non-punitive feedback is essential for encouraging honest reporting. As we conclude, what we look forward is our collective focus must now shift towards tangible application across our respective healthcare networks. We must commit to strengthening regional collaboration by establishing open channels of communication and rapidly sharing vital insights, regional trends, and patient safety innovations. Furthermore, we also encourage you to share the templates, to standardize them, and assist in strengthening our reporting systems across our countries. Also talking about the next step, so we have our next webinar coming up on 23rd of July on hemovigilance in healthcare, surveillance, safety, and continuous improvement. The time would be same 3 p.m. Indian Standard Time, and the registrations are now open. And you may use the Google Forms or the QR code that will be shared shortly to register for the webinar. Also, Dr. Kanika told me there are a few queries regarding the certificate. So we have decided that we'll be sharing the certificates at the end of the webinar series with all the participants, and those who attend nearly 75% of the sessions, they will be awarded the certificates. Thank you, ma'am. Handing over back to you.
Thank you, Dr. Nishant. And if I would again like to thank everybody, specifically Aparna ma'am and Srinivas sir, for showing their unwavering trust and confidence in us in helping us take the initiative forward. Sir, if you want to speak any few words before we close the session.
Thank you, Dr. Kanika. I saw many A's there. AIIMS, Agarwal, Dr. Arun, Aparna, Alvin. Everybody's A's. I'm the leftover, the last S, Srinivas. So congratulations and a wonderful discussion. I don't know how many people have logged in, and I'm sure the recordings will be available for the posterity. And I must congratulate all the speakers, especially Dr. Alvin, that from the Singh Health, you could bring your experience, which is actually sensitized over us. Now, I have some homework, some things I have noted down. One, I think proactively somewhere we need to start. This is a collective responsibility. And of course, Dr. Alvin will be, we will be requesting him for the support. Patient safety officer concepts. I think somewhere, though we have in some of our institutions, but I think somewhere we need to make it universal. Because unless and until commitment comes from an officer who is in charge of this in every hospital, the commitments will not percolate, the systems and process will not be put in place. I think that's a fundamental thing which we must do it, and definitely we will take it forward. The national reporting system, again, as has been told by at least two speakers, there's something which we will definitely work on that. And then, as we talked about the GP SAP 2030, I think, we should not be lagging behind. In fact, my request to the WHO is that, somewhere we need to establish here. There are people, they look into the leaders, Dr. Ramesh Agarwal, Dr. Kanika, Dr. Nishant, and the team in the AIIMS. I think they have taken that initiative long back. 10 years back also, I used to hear from neonatology and pediatrics that, patient safety, root cause analysis, and all that. I think somewhere we need to take this leadership to a logical conclusion, make it institutionalized, and bring those benefits to the national level, and then beyond to the regional SARC nations, SEARO nations, and something which is important. And then, as you said, the many speakers told about it's not the weak system, it is the not the bad people, but it's the weak system. This is something which we need to create. That means there are good people, but it's important that we create good systems also. And I'm looking at that, Institute for Patient Safety and Quality. I think somewhere the leadership has to take up this call. And my request to all of you is that, if you think that, you are not in a position to bring everybody on board, it involves Ministry of Health, Law and Justice, and quality assurance, accreditation councils, medical councils, and a whole lot of private players also. If you think that, it is coordination is a problem for you, we can take at the Niti Aayog the leadership and coordinate, and then see to it that, we will have a one-day brainstorming by the experts, not only from the Dr. Alvin and the Singh Health side, but also the Indian side, and then the WHO can be a sort of catalytic in this, and then we will take it forward so that we make some sort of policy document and advocacy for this country also. I'm looking at two things. One, how the organization from my side can take it as a policy and advocacy and then put everybody on board. The second is that how are we going to institutionalize this and somewhere an institution for patient safety and quality in India, which will have international standards, and then the training center for at least CRO and the SAARC countries in the world. Over to you, Dr. Kanika.
Sorry. Thank you, sir, for your words of wisdom. And we will definitely strive to make incident reporting and learning a national initiative, as was highlighted by Dr. Arun also, Dr. Ramesh also, that it is extremely important that we look forward to creating a national database so that the burden of harm is actually calculated in the country. We really don't know what the burden of harm is in the country when it comes to different patient safety incidents that we are looking in at, and that can be brought in by standardization and by using disruptive technology and by using disruptive innovations and getting in technology in the foray for this. If anybody of y'all have anything to say, otherwise we will close the session for today. I sincerely thank you from the side of the Quality and Patient Safety Cell at AIIMS New Delhi for helping us take this initiative forward. We look forward to your cooperation and collaboration in the future sessions as well. And we look forward to seeing you on the next session on hemovigilance on the 23rd of July. So thank you so much. Thank you.
Thank you all.
Thank you.
Thank you.